like there's...
Looks like we're now streaming live on Facebook.
Yeah, it's getting set up.
Oh, okay. Mine just popped in and it says we're now streaming live.
Right, I know on Zoom. Oh. Okay. I just want to, I see it on, that's videos, here we go. I just wanted to get to the window so I can see the, there we go. I just want to, okay. All right, I see it on, oh, my hearing, getting feedback. Let's here we go. Okay, I don't know why I'm getting like a delay. I just wanted to get to the window so I can see the, here we go. All right, well, hello everyone. All right, I see it on, oh, sorry, hold on. Hearing, getting feedback. Okay. We have a little bit of a technical problem. Sorry, hang on. Okay, can you hear me?
I can hear you.
Okay, well, you can hear me via Zoom. Sorry, I'm not seeing the Facebook, but I'm gonna get started and hopefully the people on Facebook can hear us. Hello, everyone. Want to introduce Dr. Dan Shumer. He is the pediatric endocrinologist and clinical director of the Child and Adolescent Gender Clinic at Mott Children's Hospital at the University of Michigan in Ann Arbor. And he has generously offered to share some time with us today to talk about adolescent gender transition, including hormones, blockers, how to get started, and even how to access services during this quarantine. So I'd like to turn this over to Dr. Shumer. If you have any questions while you're watching the live, please comment on Facebook and we will be sure to get these to Dr. Shumer.
Thank you, Roz. And maybe if there's someone out there that can just send a message saying that you're able to hear us, then that would make us feel great that we're coming in loud and clear. But first of all, I just wanted to introduce myself, Dr. Daniel Shumer, pediatric endocrinologist and the clinical director of the Child and Adolescent Gender Clinic at Mott Children's Hospital. That clinic has been was established in 2015 and serves transgender young people, adolescents, and young adults to provide gender assessments, mental health assessments, psychiatry, hormones, and blockers. So the first thing I wanted to say is that we're all in this COVID moment together, us at the Gender Clinic included. We're learning new ways to help our patients every day. Doing telemedicine is something that, to be honest, I was a little resistant to going into this epidemic and had been dragging my feet to learn about how to do it. And boy, did this pandemic change that and made me so excited to learn how to do that. If you are out there wondering if people are still seeing patients, still seeing trans young people and helping them get the care they need, the answer is an enthusiastic yes. If you are in need of care, you would have your child's primary care doctor send a referral to the pediatric endocrinology at the University of Michigan, with the reason for the referral being Gender Clinic. And our clinic remains open as it always has been to meet and help virtually for the moment, and then in the hopefully not too distant future, back face to face. So as I'm talking, I'm hoping that Roz can collect some questions, but in thinking about what I wanted to talk about today is just a little bit of history about gender clinics and then where we are today about how I approach the intersection of gender identity and the doctor's office, and what sort of medical questions patients and families and doctors are working together to try to answer. The very first pediatric gender clinic opened about 25 years ago in Amsterdam, the Netherlands. And in this clinic, they were thinking to themselves, gosh, we're meeting with all these families who have a child who is saying to their parents, I'm not a boy, I'm a girl, or I'm not a girl, I'm a boy. And then we're watching that child go through puberty and have a really hard time. And wouldn't there be something that could there be something that could be helpful? Because it seems like we're sort of powerless to help. They were thinking to themselves, gosh, that process of going through puberty in someone that is identifying as the other gender is so sometimes traumatic and painful that wouldn't it be great to intervene right at the start of puberty? And so they decided that, yeah, that would be the right time, but ethically, maybe not the right time to be making permanent decisions. If puberty starts when you're 10 or 11 years old, they didn't think that starting a gender transition at 10 or 11 years old made that much sense from a safety and ethical perspective. So they said, well, what if we used medications that paused puberty, and then we didn't have to watch the child go through the wrong puberty, make changes to their body that were causing them distress. And at the same time, we could buy time. We could wait until the child was older. And they ended up using age 16 at the time because that was the age of consent in the Netherlands. And then by age 16, they would have never gone through the wrong puberty. They could consider starting to go through the puberty that matched their gender identity by using testosterone or estrogen. And so this became what was called the Dutch model, where a child that was identifying as the other gender, we would watch until puberty was just starting. Then we would use medications to pause puberty. And then when they turned 16, if they still felt the gender identity to be different from the sex assigned at birth, then they would be eligible for testosterone or estrogen. And then, flash forward 30 years later, some things are the same and some things are different. One thing that I think is much different is the complexity of the types of people that we see every day in the office. So remember in the Netherlands, they were describing the typical story being someone that was a young child, pre-pubertal, that was transgender, and they were waiting until puberty started and then starting blockers, and then at age 16 starting hormones. Some of the things that really doesn't resonate with me today is, number one, we're seeing kids across all ages. So some kids are already 17 or 18 before they know that there's something different about their gender identity. They're not, pre-pubertal. In fact, in our clinic, the majority of kids are post-pubertal. They're older than puberty age by the time they come see us. So about 60% of kids are older than 13 when they come to see us, and about 40% are younger. And so maybe the use of blockers is not as much of their story. It's more thinking about testosterone or estrogen. A second thing that doesn't quite register today as it did back then is that we understand gender identity to be much more complex and less black and white. So, I think that when the Dutch wrote this protocol up, they were not really thinking that there was anything other than cisgender and transgender, that they weren't seeing people that identified as a non-binary person, or that had fluidity or change over time to their gender identity. And so I think the fact that we now think of gender identity more complexly, it adds a layer of complexity to some of the medical decisions that we make. And I think the third thing that's a little bit different today is that age 16 is not the age of consent in the United States. And perhaps you might think that someone who is living as the other gender for years and years and years might have a hard time waiting to start puberty until they're 16. That might be cruel and unusual punishment to wait to start testosterone or estrogen for some kids until they're 16. For other kids, 16 still seems young to be making that decision. I think the point there is that what doesn't seem as relevant today is having a hard and fast age cutoff for certain medical decisions, that every patient and every family is different, and using more patient and family readiness rather than an age has become the American model today. So sort of to summarize the differences today from 30 years ago is that some kids are presenting later and maybe aren't needing blockers. Some kids are identifying not so black and white as trans or cis, but more non-binary, and how do we adapt our medical decision to that? And then the timing of different therapies, to me, is more related to social readiness and family readiness, much more important than an age. Sort of with that, so I see one question that that was brought up: at what age does it make sense to start seeing an endocrinologist? My child, who is born male and identifies as female, is 6, socially transitions at age 4. You know, I think that there's not a need to see an endocrinologist right now, unless you are feeling like you just want to get connected to clinic and start talking to a doctor with your child about gender and puberty. I think that the average age that someone starts puberty is age 11 in someone born male, and it's early to think about starting puberty before age 9. So I would say age 9, 8 or 9 is a way to is an age to consider having that referral placed, so that that we can make sure that there's not early puberty, and talk about some of the medical options for the future, and put a plan in place that we're monitoring for the start of puberty. So long story short, I think anyone can come at any age. A 6-year-old with their family can come to learn more and meet the doctor and talk about sex, gender, and puberty in an age-appropriate way. But we're not likely to need to do anything medically until closer to, on average, 11, but at the earliest 8 or 9. So with that, I thought I would just talk a little bit about how I think about the medical approach to gender dysphoria. So first of all, I think about gender identity as a human characteristic, and everyone has a gender identity. I do, you do, your child does. And sometimes gender identity matches our sex assigned at birth, sometimes it doesn't. And if it doesn't, I don't think of that as a medical problem. What can be sort of thought of as a medical problem is what we call gender dysphoria. Gender dysphoria means having some distress because your body is changing in a way that you don't want it to, or that your body isn't as masculine or feminine looking as your gender identity. And if you think of gender dysphoria as a medical problem, then you can start to say, well, if it's a medical problem, what are the treatments? Well, I think one treatment could be things like social transition. If someone is experiencing gender dysphoria, perhaps wearing different clothes or wearing their hair or using a different name or pronouns could help reduce dysphoria. And then the question is, do medical interventions help reduce gender dysphoria? And to that, I would say, well, I think it really depends on the individual. And we have these tools in our toolkit that we can use. And we think about each of these tools and say, could this intervention help reduce someone's gender dysphoria, or help them live the life that they want to live? And blockers are one tool. Testosterone and estrogen are tools. Surgeries are tools. other medications or tools, all of them are potentially useful for individuals. And then we think about what's useful for your individual. So for example, blockers. A blocker is a tool that puts puberty on pause. So if someone is at the beginning of puberty and we can tell that those first few months of puberty, the breast budding starting, or the testicles getting bigger and starting to make testosterone, that continuing down that path could be harmful, then blockers could be a great tool to put puberty on pause, let the child get a little bit older, and then be able to make a more balanced decision about testosterone or estrogen a couple years down the line. What about someone who's already 17 years old? They've already gone through female puberty and they are maybe not ready to talk about testosterone yet because that seems sort of serious to them, but they really want to do something about those periods that come every month. Would they be a good candidate for a blocker? Well, a blocker would stop their periods, but there's a simpler way to stop periods. So for example, using non-estrogen birth control pills or Depo-Provera shots. These medications can be a tool that a doctor could have in their toolkit to say, this is someone that's having a problem with periods. How do we address the periods? We could stop the periods with medication. What about a transfeminine person who is maybe not ready to start estrogen, but really wants to do something to slow down facial hair development? There's a pill called spironolactone that might be a good tool for that person. So really identify what's the problem that we're trying to address. Is it puberty that's starting? Is it periods? Is it hair growth? And then is there a tool in our toolkit that can help address that problem? Testosterone and estrogen are tools in our toolkit. If someone is interested in more masculine, having a deeper voice, going through male puberty, testosterone might be a help. If someone is interested in looking in more feminine, having a more feminine body shape, having breast development, estrogen might be a good tool in the toolkit. I think about the difference between testosterone and estrogen and the other tools that I've mentioned so far. Those are the only ones so far that I've mentioned that have some permanent change associated with them. If someone's starting testosterone or estrogen, what we're really aiming for is to have their testosterone or estrogen level be in the normal range for a young man or a young woman their age. And if someone is on testosterone, we would expect the voice to get deeper. And if they stop the testosterone, the voice would stay deeper. If someone is on estrogen, we would expect them to have breast development. And if they stop the estrogen, they would continue to have breasts. So the decision around testosterone or estrogen can be thought of as a little more important from that standpoint, that there's some permanence to those decisions. On the other hand, perhaps a really good candidate for testosterone or estrogen is someone that's saying, you know what, I am darn sure that I want to look the rest of my life more masculine or more feminine. Because, when I think about the goal of testosterone or estrogen, I think about, sure, the child's goal might be, I want to use testosterone so I have a deeper voice, or I want to use estrogen so I have more feminine shape. My goal, and oftentimes parents' goals, are, is this medication potentially going to make my child have a happier, healthier, more productive life? And if they're pretty dang sure that that life is going to be lived as a man or as a woman, as the case may be, then looking more like a man or a woman could be very helpful. That being said, I never think of any one medication, testosterone, estrogen, blockers, I never think of any tool as the silver bullet for all of life's problems. So if for example, a child is suffering from some anxiety and depression and also gender dysphoria, and we decide to use blockers or testosterone, etc., then I might hope and expect that some of that depression and anxiety that is going hand in hand with the dysphoria could get better. but I'm not expecting it to solve all of life's problems and for the sky to open and rainbows to appear and unicorns to fly around. I'm expecting that improvement in mental health comes with the appropriate gender care treatment plus the mental health treatment that we all know is so important for someone suffering with depression or anxiety. I can take this talk in many different directions in terms of going into more detail about blockers, testosterone, estrogen side effects, those sorts of things. But I also don't have a great sense of who's listening and what questions might be out there. One thing that I would like to share is what an amazing opportunity it is to care for transgender young people and their parents, that I feel like every day I get to meet really, really brave people. I say that thinking about the kids because being a kid or a teenager by itself is pretty complicated, and throwing in a difference of gender identity on top of that can be quite complicated. And for parents, the thing that we know is most important, even more important than any of these medical decisions, is your unconditional love and support. And I just get to meet parents that are sorting through a really complicated thing with their kids every day. One of the questions that popped in was, would a 13-year-old need an official diagnosis of gender dysphoria from a gender therapist before coming to the clinic? The answer is no. That if you're referred by the primary care doctor, or if you're having trouble with that referral, you can also call the endocrine office at, and Roz, maybe you could post this number, 734-764-5175, and ask to talk to Kara, K-A-R-A. But someone that doesn't already have a therapist that has seen the child that has diagnosed gender dysphoria, they would be offered an assessment with one of our social workers. And I'm gonna type the number to you. So when someone's referred without a therapist, then they're offered an assessment with one of our awesome social workers, and that social worker can help confirm a diagnosis of gender dysphoria. So not a requirement to be in therapy or to have a current therapist to get care. Another thing that I wanted to talk about is that earlier today, there was a really cool thing that happened. There was pediatric endocrinologists and adolescent medicine doctors from across the country that got together on a Zoom call and talked about how we're providing care during the COVID era, and sharing stories about what's working, what's not working on video visits, what are some of the challenges, tricks on how to teach someone to do testosterone shots over video. And so, I think there's a group of doctors across the country that are trying to think about providing the care in the crazy times that we're living in, and sharing ideas with each other. How does the clinic prepare 18-year-olds for transition into adult care? It can be difficult for trans adults to get access to care due to wait lists for available doctors. Yeah, so I think transition to adult care, or I call it graduation, because then there's too many transitions going on, right? Some of the things that I think about where a young person might be getting ready to be transitioning to adult care are that they know their medications, they know how to contact their doctors to schedule appointments, and And there fortunately are really good adult doctors at U of M and in other parts of the state as well that I send people to that are getting a little too old for pediatric clinic. We're allowed to see patients into their 20s, but at some point the patient is like, I think I'm not a kid anymore. I'm done coming to the children's hospital. And so from that, in that 18 to 20 year window, I'm oftentimes working with young people about, getting ready to make that graduation and some options for who to see. And then, as I get to know them, I might get a sense for who might be a good fit for them. Another question, what are major side effects of blockers? Does it weaken bones and lower iron levels? It's a good question. So I think it involves talking a little bit more detail about what blockers are and what I mean by blockers. So when people say blockers, what they're most often talking about is something called a GnRH agonist medication, which is basically the medication to completely stop puberty. And that is given as an every 3 month shot, or it's given as an implant that goes under the skin that lasts for 1 to 2 years and then can be replaced. And what that medication does is it basically turns off the signals in the brain that tell the testicles or ovaries to make testosterone or estrogen. And so you're basically turning off puberty like a switch. When I say blockers, I mean those medications, but I also could be meaning like medications to stop periods or stop hair growth. But I think what the question asker is asking about are those blockers that completely stop puberty. If you think about puberty, what are the things that happen during puberty? Well, you get all those puberty changes that we've been talking about: voice deepening, masculine appearance or feminine appearance, breast development. And so if you are stopping puberty, then you're preventing those things from happening. And I think that's sort of the point that the Dutch were trying to capitalize on. But are there other important things that happen during puberty? Absolutely. You go through a growth spurt, your bones get much stronger. So if you're delaying puberty, you would expect that you're not going through that growth spurt. You're going to continue to grow at a pre-puberty speed, but you're delaying the growth spurt. Your bones are going to get stronger, but they're not going to get stronger in a big spurt like they would have during puberty. And so if you are, for example, never going to go through puberty, say you're born without testicles or ovaries and no one ever gives you any hormones, you're going to have weak bones because you're never going to get that puberty surge in bone strength. What if you go through are on blockers for a couple of years and then you start testosterone or estrogen? Well, then you would expect that on testosterone or estrogen, you're going to have some catch up in your growth spurt and your bone strength. And there's some studies that show, if you are on blockers for a short period of time and then start testosterone or estrogen, that there's not a measurable difference in bone density. But what I am worried about is someone that starts puberty when they're 10 and then they're on blockers until they're 16 or 17 and then they start testosterone or estrogen. We're really robbing that person of 6 years of bone strengthening from puberty. And so for that reason, I think we're also a little weary of using blockers for years and years and years and years, because I do think that could be associated with weaker bones. So to answer your question, I think that blockers are safe for most people for 2 to 6 years, but indefinitely it wouldn't be a good thing to do because it could have some effects on bone strength and growth. Another question, do I see intersex patients? The answer is yes, but there's a different clinic that I participate in called DSD clinic at U of M, and I'm part of that clinic as well, where I see intersex patients with other people like the genetics and urology colleagues that can sometimes help in people with intersex disorders. So if you are someone that is needing to get connected with a DSD clinic, there's a DSD clinic at Mott Children's Hospital that you could connect with, and you could use the same number that Braz has posted to find out more. DSD stands for Differences in Sex Development. And another question is, what about for non-binary people? Well, that's a really good question. And I think the answer is, it depends on what that non-binary person is wanting and needing. So for example, if I am a non-binary person that says, you know, I was born female, I identify as non-binary, and to me that means my gender identity is in the middle between masculine and feminine, and I don't have any distress over my gender identity when I dress in a masculine way, then that non-binary person wouldn't need any medical intervention. If that same person says, I have distress because my voice sounds so feminine that I am gendered as female all the time, and I wish that I were gendered more androgynously, or that people had that people would recognize me as a non-binary person, that person might benefit from one of the tools in the toolkit, right? So maybe a temporary course of testosterone to lower the voice would be something that person could consider. And in that way, they would have a deeper voice, but they wouldn't have, the masculinization of going through all of male puberty, and that distress that they had around their voice could be improved. So, and then maybe that same person says that I'm a non-binary person that wants a deeper voice and a beard, and I want to look as masculine as anyone else that identifies as male. And maybe that person then would benefit from continued testosterone. So I think to answer the question, you really need to ask the person, well, what is important for you? And what tools in our toolkit can we use to address your concerns? Does synthetic testosterone cause a growth spurt? That's another question that was raised. So the answer to the question is yes, although if someone is done growing, if they start, so for example, are born female and went through female puberty and haven't gotten any taller over the last couple of years, testosterone will not get them to be taller. And then again, if someone is still growing, then testosterone does contribute to a growth spurt. Another question is, moving from pediatric medicine to adult care, is maintenance able to be safely overseen by a general practitioner, or do they need to be seen by an endocrinologist? It's up to the general practitioner. So I certainly know many primary care doctors and family medicine doctors that are comfortable continuing someone's testosterone, and many that are not. So if one of my patients who's becoming a young adult says, I really love my primary care doctor, they're really great, but I need to find another specialist for hormones because they're not comfortable with that, then I would say, great, keep your primary care doctor, and here's a hormone provider that can be your specialist. If they say, gosh, I don't really have a strong attachment to my general primary care doctor, is there someone that you would suggest that could be my regular doctor, my general practitioner, and my hormone doctor? Then I would say, yeah, I have a person in mind. So either way. Another question, what age is recommended for ovarian removal for trans males? Good question. This is an area that's sort of a moving target. I would say that in the past, there was this thought that everyone that was on testosterone would want and need a hysterectomy, oophorectomy, take out the uterus and ovaries. More recently, I think we're thinking about it in a different way. that we're not necessarily seeing that every trans man has to have a hysterectomy, oophorectomy, that there was a question in the past of, is there danger of leaving them in? And as we're getting more longer term data, we're seeing that if there's not problems like cramping or spotting or dysphoria just associated with having those organs, then there's not necessarily a medical reason to take them out after a certain amount of time. And so there is now many trans men that are leaving their ovaries and uterus in place, and not just reflexively having hysterectomy just because they think they need to. So that has changed, because in the past there were different feelings like after 5 years or 10 years on testosterone, you should have have those organs removed. Nowadays, not so much. If someone does want them out because they have dysphoria associated with them or they're having cramping or bleeding or some problem, the most OBGYN doctors that work with trans guys are hesitant to do that before age 18. And part of that is because the ovaries and uterus are still a reproductive organ that can participate in fertility. And when we're young, even if we're not sure that we want to use our body to make a baby, there's still a feeling that it's an adult decision to completely reverse fertility potential. So I would say that most OBGYN doctors that work with trans guys are hesitant to do any uterine or ovarian surgeries before age 18. And then the OBGYN is going to counsel the guy about the pros and cons of hysterectomy, oophorectomy. Those surgeries are done by folks at U of M in the Department of OBGYN that are really comfortable working with trans men. Pap smears is another question that someone asked. When are we supposed to get pap smears? So trans men, similar to cis women, current recommendations are 3 years after first intercourse, that's penile vaginal intercourse, or age 21. So if someone is having intercourse starting at age 16, then that would be age 19 that they should be having their first pap smear. If they aren't, then everyone fits into the category of recommended pap smear at age 21. I think that there are doctors and providers out there that recognize that doing pap smears or other invasive exams can be really traumatic and anxiety provoking for trans men and trans women. And doctors out there that are really sensitive about that and work with young people and young adults and older adults to make that even more comfortable. And at the same time, no one is going to do an exam that you're refusing or uncomfortable with. A question, what age should male to female children start on blockers? Well, there's no need for a blocker before puberty starts. The very first time that a blocker could be considered is at the start of breast development. And so the age that breast development starts on average is around 10 and a half, but can range anywhere from 8 to 13. So if someone has a male gender identity, oh, sorry, the question was about male to female children or transfeminine children. So the very first time a transfeminine child could benefit from a blocker is when male puberty started. And that's a little trickier than female puberty, because in female puberty, you can sort of sometimes see that breast budding starting. In male puberty, the very first sign of male puberty is the testicles getting a little bit bigger. So if I see a child around puberty age in my office, I would be monitoring the size of the testicles and watching to see when those testicles are starting to get a little bigger. And usually that happens around age 10 and a half to 11, anywhere from 9 to 15 really, but the average is around 10 and a half to 11. So if you have a transfeminine child who's, somewhere between 9 and 11, and you're not sure if they've started puberty yet, then we could see them and do an exam and see if puberty has started. And if it had, then they would be a candidate for blockers. If they've started puberty a couple of years ago and you know that, then we could think about blockers or estrogen, depending on where they're at and where you're at. What's the difference between implant versus shots in terms of blockers? So really just the way that they're given. It's the same medicine given in a different way. It works the same. So the implant is called Histrelin, and sending these two words to Roz to include in the feed. Histrelin is the name of the implant and Lupron is the name of the shot. And really the biggest difference is that the shot is just like a shot and you get it every 3 months. And the implant is put in right here on the inside of the arm, that I make a little area of the skin numb. I make a little slit, and then I put the medicine, it's like a little rod under the skin here, put a little stitch here to close it up, and then that stays under the skin for a couple years to keep puberty paused. So I would say that if it were me, I would prefer the implant because I would not have to get a shot every 3 months. I could get something in my arm and not think about it for a couple of years. But if I was really worried about having a little procedure done, maybe an every 3 month shot would be a little less involved. Another question, can I talk about bottom surgery and sexual pleasure? So I can try. I think that the first thing I wanted to say about bottom surgery and surgery in general is that just like the things that I've been talking about already, it's a tool in our toolkit. So for someone that is, let's say, a trans woman, she might say, having a surgery to create a vagina is something that's extremely important to me. And another trans woman might say, I don't need a vagina to feel good about myself or to reduce my dysphoria. It's not important to me. And both of those people are equally valid in how they feel, right? So someone that could benefit from bottom surgery would be someone that having a change in their genital anatomy is extremely important to their to reduce dysphoria and affirm their gender identity. And when I think about the two types of surgery, the surgery to create a vagina is called a vaginoplasty. And in that surgery, the head of the penis is, it becomes the head of the clitoris. And then the skin of the penis becomes the inside of the vagina. And so the surgeon is really trying to do everything they can do to keep those nerve bundles from the head of the penis and include those as the new clitoris with the intention of maintaining sexual pleasure and sexual function. And in the masculine bottom surgery, there's actually two surgeries that people consider. One is called metoidioplasty, which is basically taking the labia and closing them and stretching to make a small phallus and using the head of the clitoris to become a small head of a penis. The end result of that is no cutting to the nerve bundles of the clitoris. And the end result is a small phallus. Another option is something called a phalloplasty, which means taking a big graft from your arm or your leg to create a larger and longer phallus. The result being a more I guess, natural looking phallus that's larger. The con of that being it's a more involved surgery. There can be more complications with strictures and potentially worse sexual function than in metoidioplasty. So at the end of the day, though, in both of those surgeries, the surgeon are attempting to maintain the nerve bundles so that sexual function and pleasure are maintained. But that doesn't necessarily mean that sexual function and pleasure are the same after surgery as before. And there are some studies coming out to say that there's some impairment in sexual function and sexual pleasure. I think it goes back again to this toolkit question, right? So if someone would never even consider engaging in intimacy with their genitals the way they are, and would only consider it after having surgery, then perhaps a partial reduction in sexual function or sexual pleasure is completely acceptable to that person. On the other hand, if they are someone that's sort of content with the anatomy that they have and enjoys sex and is just considering surgery because that's what they think they might want, they really have to think about the pros and cons. So a question about top surgery and COVID-19 is U of M during quarantine doing surgeries. The surgeries right now, top surgery and genital surgeries are being delayed. And I don't have a clear sense for when the surgeries are going to continue again. My sense is that there's a slow reopening of clinical services at Michigan Medicine starting in mid-May, and with a goal of having most of the clinical operation open by mid-June. So I think that, this is all uncharted territory and these dates can change, but I know that people that were scheduled for top surgery at U of M that were scheduled for April or beginning of May, I believe are being rescheduled to June and July. A question, what is the recovery period for vaginoplasty? Would they need care from parents? So bottom surgery is more of a recovery than top surgery. That is certainly true. Top surgery is a recovery that can take several weeks to feel better. Bottom surgery can take a few months to be able to feel like you're ready to go and not need not having pain with normal everyday movements, not needing support from a support person. So I think that having someone in your life that is able to help after vaginoplasty surgery is not only important, but it's mandatory. That the surgeon will want you to identify who are your support people, who is the person that's going to help you into the wheelchair, into the car to get you home afterwards, who's going to help you change the dressing if you need help, who's going to help you with your medications. And if that's a parent, then great. I think that it doesn't have to be a parent. It could be a best friend or a cousin or anyone else, but it's really not advisable to do vaginoplasty alone with no support person. What's the hardest part of my job? That's a really good question. I think the hardest part of my job is working through family conflict sometimes. I I see so many different families with different approaches to gender dysphoria. And I want to say at the beginning of my statement that I generally get the sense from parents that they love their child, right? And they're trying to make the right decisions with their child and for their child. And I think that some of the most challenging parts of my job have been when there's parental conflict, maybe divorced parents, and they're seeing the same child and thinking that different things are going on, or they have a different approach to how to best love and support their child. And trying to navigate those conflicts in a caring and sensitive way, it can be challenging. But my goal at the beginning of those types of visits are to meet parents where they're at and to validate them and say, how you're feeling is normal. Here's some of the things that we know about what parental support means and the benefits of parental support. Here's some of the things that we've learned from your child. Here's some of the things that we think might be helpful. And one of the things that I have seen is that parents that are non-supportive of a transgender child can become more supportive with that type of education. And I also just have to oftentimes stop and remind myself that support and love are two different things. A non-supportive parent can love their child, and I can use that love to say, your child's really suffering, child that you love is really suffering, and support of their gender identity is something that could help that suffering. And let's see, what other hard parts of my job? Going back to the question about graduation to adult care, I think one of the things that I do the poorest in is getting patients to see adult providers, because I found that I'm sort of a pushover, and they say, oh, I know that I'm 21, but can I just stay with you for one more year? I know I have a feeling that they would get better care if they started to see the adult provider, because they are more confident in things like pap smears and some of the adult care pieces that start becoming more relevant. But I have a hard time saying goodbye. And so I think that one of the hardest parts of my job and things that I need to work on is being able to make that graduation to adult care happen, thinking that it's probably best for my patient. The female to male guys can go to a GYN, but what about male to female? So interestingly, there's no one type of doctor that can be a trans health doctor. At U of M, the doctors that see the most trans guys and trans girls are both are GYN doctors. So there's a group of 4 GYN doctors at U of M that will see trans men and trans women. Their names are Dr. Stromza, Dr. Randolph, Dr. Chrisman, and Dr. Moravec, and we can post their names on the stream. And then there's primary care doctors that will see trans men and trans women. And so the answer to the question is yes, there are awesome GYN doctors that can take care of trans women and trans men, and awesome family practice doctors and primary care doctors. And it just kind of depends on, do you want your hormone provider to be sort of your primary care doctor as well, or do you want your own primary care doctor and a specialist? And usually that specialist would be an endocrinologist or a GYN. A question popped in: how many trans or non-binary patients is your clinic treating? I don't have an up-to-date number, but my estimate is somewhere between 400 and 500. patients from across the state. We see about 100 new patients a year, anywhere from the Upper Peninsula to the west side of the state to Ann Arbor and everywhere in between. Do hormones conflict with antidepressants or mood stabilizers? No, I would say that many of the patients that we take care of have co-occurring anxiety or depression and could benefit from anti-anxiety or antidepressant medications that can be safely used in conjunction with hormones. We have about 5 minutes left, so if anyone else has any questions, don't run out of time before you type it in. How did I get interested in this specialty? That's a really good question. Probably a lot of different reasons. I knew I wanted to be a pediatrician because I like working with young people. And then in my training, I had an opportunity to meet with a doctor named Dr. Norman Spack. And he founded the first gender clinic in our country for youth in Boston. And I was able to observe a visit with him with a family. And I was just blown away by how helpful he was to that family in sort of taking away their fear and shame and replacing it with love and hope. And that visit just got me super excited about working with this population of patients. And then as I became more interested, I got to work with him and see a bunch more patients. And I got the sense that, when most adolescents go see the doctor, they're not excited to be there. And I got the sense that when I was in gender clinic, those young people were actually excited to be there. They had been circling that day on their calendar for a while. And I got a real sense of joy out of, meeting patients that wanted to see me and I wanted to see them. And that we were having really meaningful, important conversations about something that was really important. So it's been a lot of fun to participate in gender care. Really, really rewarding. The best part of my job, is our last question. The best part of my job is getting to meet amazing young people every day. And, how hard it must be to sometimes drive across the whole state to meet a doctor, a stranger, and talk about really private and scary topic. That takes a lot of courage and a lot of guts. And I get to meet those really, really brave kids every day. And that keeps me motivated and makes me excited to get out of bed. And I would say drive to work every morning, but now it's just going down into the living room. And it keeps me excited every day to keep doing this job.
And that was amazing. Thank you so much. There are still questions popping up. I don't know if you want to take one more, depending on the time. It's 3:58. Sure. I'll do one more question. All right. So how has your work changed your personal parenting perspectives about gender?
That's a good one. So we have a 3-year-old. Me and my husband adopted, and our son Charlie is now 3. And I think that probably my parenting style may have always been to sort of let give the child lots of different options in terms of toys to play with, things to pursue. But we know that we're all born into a very gendered world. And, even subconsciously, I wonder to myself sometimes, am I treating my child differently because I know his sex or not? Or am I doing anything that is that is different than I would be doing if my child was a daughter? But what's interesting to me is that, we see gender stereotypical behavior at such a young age. My son is doing things that his female cousins aren't doing, and vice versa. And on the other hand, that doesn't necessarily mean anything, because I hear all the time from some parents that, yep, they could tell their child there was something different about their gender identity ever since they could talk or walk. And then other parents that say, you know what, that's not my story at all, that there was nothing different about gender expression until, puberty. And then I started hearing about how different they felt. But, I think that, one thing that I like to say about parenting is that we naturally, as parents, form a picture in our mind about what the future is going to look like. And then as our child grows up and starts talking and telling us about them, then we start learning different things, and that changes what that picture looks like. And sometimes those revelations that we get from our children are small things like, I hate baseball, I only want to play soccer. And then that dream of mine of a baseball player has to be replaced by a picture of a soccer player. And that doesn't take a big mental hurdle, right? Okay, like soccer, not baseball, so what? But if my child says, I'm not a boy, I'm a girl, that takes a bigger mental hurdle. That picture looks a lot different all of a sudden. And that can take time. And some people call that mourning or grieving, or there's a process involved in the way the future looks changing. And so, I think that, being a parent allows me to, love and care about someone so much, but also keep in mind that I try to set a good example for my child, and who they turn out to be has a lot to do with a lot of things that are outside of my control. And I just have to love them regardless and support them along the way.
Amen. Thank you so much. We had lots of people watching and commenting and participating in the dialogue with our questions. So thank you, Dr. Shumer. Thank you to everyone who was on. This, of course, gets saved to Facebook, so you can all watch the video again and hear answers to the questions, and share with your family members if you think it'll be helpful, or if you work with people who work with youth, whether it be in a mental health practice, a school setting, whatever that might be, please feel free to share the video. We will be back next week, I think it is, on the 1st, with Dr. Tony Corretto, who is going to address mental health issues and LGBT youth. So everyone have a great weekend. Stay safe.
Bye.